है। दूसरी बात कि धन में आपका चंद्र बैठा।
So today we will discuss diabetic kidney disease, and diabetes is most important cause of chronic kidney disease. So it is very important topic. So coming to the epidemiology, it is the most common cause of chronic kidney disease. The prevalence of ESRD is also up to 10 times higher in people with diabetes as those without. So among diabetic, most of the patient develop CKD. So we can see in this pie chart that around 43% of the CKD is caused by diabetes, followed by 26.9% because of high blood pressure, then 7.6% because of glomerulonephritis, then 2 to 3% because of cystic disease, and 2% because of urological diseases. And pool data from 54 countries reveals that more than 70% of the end stage renal disease is caused by diabetes and hypertension or both. Now coming to the clinical stages of the diabetic nephropathy. So diabetic nephropathy can be divided into 5 parts based on the GFR and urinary albumin excretion. So first stage is the stage of hyperfiltration. Here the GFR is supernormal, more than normal, and urine albumin excretion is less than 30 milligram per day. Blood pressure is usually normal in this stage, and this stage usually develops in up to 5 years. It may take up to 5 years to develop in type 1 diabetes. But because the patient of type 2 diabetes are mostly subclinical, so in those patients, they may have latency period, and because of lack of screening, it may not be diagnosed at time. So the stage of hyperfiltration may have passed at the stage when the diabetic kidney disease is diagnosed. The second stage is a stage of microalbuminuria. Here the GFR is about normal, high normal range, and urine albumin excretion increases from 30 milligram to up to 300 milligram per day, and blood pressure shows some rising trend. It develops over a period of 5 to 15 years of the onset of the type 1 diabetes. Then third stage is the stage of overt proteinuria. Here the GFR remains stable or may start declining. The urine protein excretion increases more than 300 milligram per day. Blood pressure shows rising trend, so further elevated, and this stage usually appears after a lag period of 10 to 20 years from the onset of type 1 diabetes. And in type 2 diabetes, maybe because of late diagnosis, it may appear early. Then stage of progressive nephropathy. So here GFR started decreasing and urine albumin excretion further increases, blood pressure remain elevated, and this appears in over a period of 15 to 25 years from the onset of diabetes. Then final is the stage of end stage kidney disease. Here the GFR falls less than 15 ml per minute. The urine albumin excretion become massive, and blood pressure is usually elevated, and this appears over a period of 20 to 30 years. So this is a stage based on the duration of the diabetes and how these different stages appear. Now coming to yearly risk of death in diabetic kidney disease. So we can see that if there is no nephropathy, the risk is around 1.4%, and from no nephropathy to stage of microalbuminuria develops in around 2% of the patient, and at the stage of microalbuminuria there is 3% chance of death, and if the stage of micro to macroalbuminuria appears, then the stage of death is around 4.6%, and from micro to macro conversion is around 2.8% per year. So similarly, from albuminuria stage to a stage of rising serum creatinine and need of renal replacement therapy is around 2 to 2.3%, and this may leads to death in around 19%. So we can see that as the stage progresses, the risk of death increases. Now coming to natural history of the diabetic nephropathy. So in this graphical representation, we can see that as we already discussed the stage of increased GFR stage 1. So it is preclinical type of renal disease. Here GFR increases. We can see that from 100 to 150, it may touch up to 150. And the structurally, if we see in histopathology, there may be some kidney hypertrophy, and this stage usually appears over a period of 5 years. Then second stage is incipient diabetic kidney disease. Here microalbuminuria appears. That means proteinuria increases from more than 30 milligram per day, and GFR remains stable or status a little bit, shows declining trend, and proteinuria increases up to 30 milligram, to more than 30 milligram per day. And if we see at the histology, there may be mesangial matrix expansion, glomerular basement membrane thickening, and arterial or hyalinosis. So this stage appears over a period of 5 to 15 years. Then third stage is over diabetic kidney disease. Here we can see that GFR declines and proteinuria further increases up to more than 300 milligram per day. And this stage appears over a period of 15 to 25 years. Then last stage is end stage kidney disease. Here GFR further decreases and proteinuria further increases over a period of more than 25 years. And we can see mesangial nodules, that is also known as KW nodule, and tubulointerstitial fibrosis develops. So this is natural history. If no intervention is done, then how the diabetic kidney disease progresses. Now, what can be the factor which modulate natural history? So there are several factors which contribute to uh, rapid progression of the kidney disease, most commonly associated hypertension. Then, as we already know, that sugar control is very important. So poor glycemic control and obesity is also associated with declining renal function rapidly. High salt and high protein intake. It has been seen that high salt increases glomerular filtration pressure, and similarly proteinuria, increased protein intake in diet causes afferent vasodilatation that ultimately leads to increased glomerular filtration pressure, and that ultimately cause increased proteinuria, and that proteinuria further damages kidney over a short span of time and may leads to end stage kidney disease very early. Then several other factors like dehydration, as we know that dehydration may cause decrease in blood flow to the kidney, and similarly the GFR will fall and may further damage the kidney by ischemic kidney injury. Then nephrotoxin medication, because of several mechanism causing pre-renal or renal type of injury, can cause renal dysfunction in diabetic kidney disease. Then intercurrent infections are very important, as we know that diabetic patients are immunocompromised, so they are prone to get infected, and these infection may cause renal dysfunction at earlier at early period of life. And then associated other comorbidities like heart disease and liver disease, because there is intravascular volume depletion, and because of less effective arterial blood volume, this may ultimately leads to renal dysfunction at faster rate. Now, coming to the stage of kidney disease, the prognosis of CKD by GFR and albuminuria. This is KD code 2012 guideline. So there are several uh, parameters based on proteinuria and GFR. It has been staged in different categories. So if proteinuria is less than 30 milligram per gram, so that comes in A1 stage. That can be here we can see, and A2 stage is moderately increased proteinuria, that is 30 to 300 milligram, and A3 is severely increased, that is more than 300 milligram per gram of the proteinuria. Similarly, based on the GFR, it has been divided into five stages. G1 stages is when GFR is normal and high, more than 90 ml per minute. G2 stage is 60 to 89. G3 is further divided into A and B, 45 to 59 and 30 to 44. Mild to moderate decrease and moderate to severely decreased GFR. Then stage G4 is severely decreased GFR, that means up to 15 to 29 ml per minute. And stage 5 is when the GFR falls less than 15, that is also known as end stage kidney disease. Then we can see that based on this color coding, if the color is green, that means the proteinuria is less and GFR is also maintained, so it is not very severe. Then similarly, when proteinuria increases but GFR is preserved, so yellow category is also not very severe. But as we progress further, there's orange color coding. That means that GFR is further decreases, and proteinuria also, if very high proteinuria is there. So these are a little bit more severe. And red color is denoting that proteinuria may be high and GFR is further decreasing. So this way we can appreciate the severity of the disease. Now coming to the management of diabetic kidney disease, so what should be our goal when we see any patient presenting to us with some kidney dysfunction like appearance of proteinuria, significant proteinuria, and fall in GFR. So at least yearly measurement of urine albumin creatinine ratio should be done in diabetic patient to screen at an early stage, and serum creatinine and serum potassium are also very important. Then at a stage of 45 to 60, like stage 3B, 3A, we should refer the patient to the nephrologist. If possibility of non-diabetic kidney disease is suspected, so there are few clues to suspect non-diabetic kidney disease. That means the duration of diabetes type 1 less than 10 years, persistent albuminuria, abnormal finding on sonography, resistant hypertension, rapid fall in GFR at initiation of ACE or ARB, or active urine sediment in urine microscopic examination. Then we should evaluate the medication, and we should adjust the doses based on GFR. GFR should be monitored at a 6 month interval at least, and electrolyte bicarbonate, hemoglobin, calcium, phosphorus, and parathyroid at least should be monitored annually. Vitamin D sufficiency, vitamin D level should be seen. Patient should be counseled regarding protection from hepatitis B. So vaccination is counseling is important. Bone density testing can be done, and referral for dietary counseling, because as the GFR decreases, there is risk of hyperkalemia and other abnormalities, electrolyte abnormalities. So this part needs to be taken care. Then at stage 3B, that is GFR 30 to 34, more frequent monitoring of GFR is warranted. Electrolyte, bicarbonate, calcium, phosphorus, parathyroid, and hormone and hemoglobin, albumin, and weight should be measured at 3 to 6 month interval. And dosage adjustment is further here also needed. And if the GFR is less than 30, we should refer him to the nephrologist for the further planning of renal replacement therapy. So, what should be the diet if somebody is approaching to diabetic kidney disease, has started proteinuria? So, as we know that hypertension is associated factor, so salt intake should be less than 3 gram per day has been recommended. And then low protein diet, as we already know that protein causes afferent vasodilatation, so low protein diet has been associated with uh, slow decline in GFR. So protein should be less than zero point 0.8 gram per kg per day. Non-vegetarian food should be avoided. As we know that as the GFR decreases, there is high risk of hyperkalemia. So fruits, juice, and leafy vegetables should be avoided. Similarly, dry fruits and many uh, dry fruits contains high potassium, so they should also be minimized. Dairy products and non-vegetarian foods are rich in phosphorus, so they should better be avoided. Now, what can be the do's and don'ts in diabetic kidney disease patient? ACE inhibitor ARB prevent progression of diabetic kidney disease, but we need to be careful about risk of hyperkalemia. So frequent monitoring of potassium is important. As we know that low protein diet is beneficial in diabetic kidney disease. So vegetarian diet should be encouraged. Patient should be promoted for hepatitis B and pneumococcal and influenza vaccination because of risk of these infection because of immunocompromised state, and blood-borne infection, hepatitis B, at the time of initiation of dialysis. So, few studies have found keto analogs and probiotic to decrease the serum creatinine and uremic symptom in diabetic kidney disease patients. NSAIDs and other painkiller and nephrotoxic medication should be avoided. And PPI should not be written as a routine, as we know that many times our prescription contains proton pump inhibitor, but they are found to be nephrotoxic, causing interstitial nephritis in several studies. High salt intake also should be avoided. Uh, there is few people use N-acetylcysteine and taurine for prevention of diabetic kidney disease, but nowadays data are available that these drugs are not very useful. So to conclude, we can say that diabetic kidney disease develops in around 30 to 40% of the patients with diabetic and is a leading cause of CKD worldwide. Glycemic and BP control are the most important parameter in preventing diabetic kidney disease. Dietary counseling is an important aspect in the management of diabetic kidney disease, and avoidance of nephrotoxic is very important. ACE and ARBs may be useful for the prevention of and progression of diabetic kidney disease. Thank you so much.